Hi, everybody. This is Chris Forrest, and I'm really pleased to be talking with you today about intervention studies in learning health systems. We're going to talk a bit about clinical trial definitions, types of clinical trials, and then we're going to dive into different types of threats to study validity as they relate to interventions. Now, the material today should come in quite useful, not only for your own research, but also in the session that we're going to have in a few weeks when we talk about intervention studies. I'm going to challenge you to apply what you've learned today to a whole slew of alternative study designs that are used in learning health system science. So let's jump right into it. Beginning with the NIH definition of a clinical trial, which I think is as good as any that I've seen. It states that a research study is a clinical trial when it involves one or more human subjects who are prospectively assigned to one or more interventions, which may include placebo or other control, to evaluate the effects of those interventions on health-related biomedical or behavioral outcomes. So what are the interventions? They could be preventive care, they could be diagnostic, medical treatments, surgeries, behavioral health treatments, delivery system interventions. They may be one-time programs, one-time administration of, say, a particular medication, or they could be adaptive. So-called adaptive clinical trials are planned before the study is done, such that when a certain event happens, the intervention changes. So the easiest example to that would be for an adaptive clinical trial, someone runs a study on treatment of hypertension. And if the patient after 60 days has had no change in their blood pressure, the protocol would say add medication B or increase the dosage of medication A. In other words, the responses that we would typically make clinically are protocolized, and you're trying to reflect in the protocol the adaptive nature of clinical care. And these adaptive treatment strategies are really important for us to start studying because they reflect what happens in the real world. Now, a couple of other important characteristics of clinical trials are that they involve human subjects. That's sort of plain vanilla. But the second piece here is that the NIH defines a clinical trial as involving researchers' prospective, deliberate, and protocolized assignment of participants to an intervention or a control group. And this idea of prospective assignment is really core to the NIH definition, but it does get a little tricky because I could be evaluating an intervention that may have been delivered 5 years ago. Let's assume for a minute that 5 years ago, patients were assigned to a hypertension treatment or usual care, or patients were allowed to choose which hypertension treatment they wanted to get. And I'm going to adjust for those differences in the patient populations using observational statistical methods, so-called causal inference methods. I'm bringing this to the forefront in your thinking because a clinical trial could be done concurrently where it's clear that there's been prospective assignment. So I, as the researcher and the participants, move forward in time concurrently or non-concurrently. In other words, I might look back at something that happened years ago and do the evaluation, but maybe the evaluation was actually prospectively assigned. And it's a subtle distinction, but this is one in which Leon Gordis, the famous epidemiology who I studied under at Johns Hopkins, makes in his textbook on epidemiology, that we ought to call cohort studies. And by the way, after all, a clinical trial is just a cohort study. We ought to define cohort studies by the relationship between researchers and participants in time, either concurrent or non-concurrent. And then the other parts of the, I think, other parts of this definition speak for themselves. The first approach for thinking about trials that I'd like you to consider is the distinction between experimentation and quasi-experimentation. Now, the experimental clinical trial is one in which the researcher deliberately and embedded within a protocol randomizes or randomly assigns patients or participants to an intervention group and to a control group. In this case, the researcher and the participant are concurrent. They're moving forward in time together. Quasi-experimental trials may or may not involve, on that second row, the researchers and participants moving forward concurrently. They could be non-concurrent. The intervention is assigned in a non-random way, often allowing clinicians and patients to select, which treatment to take. And then we use causal inference methods to try to adjust for differences between the groups. And when you allow for non-random assignment of intervention, there's an intervention group, but the group without the intervention is not called a control group, it's called a comparison group. The second approach for thinking about clinical trials, which is very important for us in learning health system science, is the explanatory pragmatic continuum. This is fleshed out in great detail on the presses2.org website. There is not a sharp dichotomy between explanatory clinical trials and pragmatic clinical trials. All trials can be evaluated on a continuum across multiple dimensions as shown on this slide. So let me go through a few of these dimensions for you and illustrate what a pragmatic trial would look like and contrast it to an explanatory trial. And by the way, an explanatory clinical trial would be a trial like a phase 2 or phase 3 clinical trial that's highly regulated, highly protocolized, lots of selection criteria, et cetera. On the eligibility side, pragmatic studies try to limit the number of selection criteria so that you are reflecting real-world patient populations as much as possible, whereas explanatory trials may have 20, 30 different selection criteria. On the pragmatic side, with regard to recruitment, patients are allowed to come into care as they see fit, as their clinicians see fit. There is no attempt to bring patients in on a schedule. So the recruitment that occurs is recruitment within real-world settings, and that also gets to the setting. In a pragmatic trial, you're often running the study within busy clinical settings, as opposed to a research study where the patient may come back for special research visits. There's very little attempt in pragmatic studies to ensure that patients are adhering to the intervention. Sort of routine clinical practice is used. And the primary outcome is a really important one. On the explanatory side, most of those clinical trials are going to try to get as close to changes in biology as possible, because you're trying to reflect the intervention's influence on biologic changes and then take those inferences and often make claims about a surgery, a behavioral health treatment, or a medical treatment. On the flip side, pragmatic studies sort of grab whatever outcomes we can, certainly outcomes that are readily obtained, such as patient-reported outcomes, outcomes that can be obtained as part of routine care, blood draws, et cetera. So I encourage you to study the Presses framework. There was a early Presses paper, and then the revision, and then that website actually goes into it in more depth. And what you will see is that every trial can be arrayed on a continuum. You can imagine then filling in this radar chart with a clinical trial, and some tend to be more pragmatic and some tend to be more explanatory. Now let's dive into study validity. We're going to start with internal validity and then move into external validity. Internal validity asks the question, are the inferences about the intervention effects both correct and credible? Internal validity is the extent to which a study can establish a credible, that is, a believable to external audiences cause and effect. Validity is not either demonstrated or not demonstrated. A study is not valid or not valid. A measure is not valid or not valid. Don't fall into that trap and think about validity as a dichotomous phenomenon. It is a phenomenon that requires evidence to be accrued. So you actually evaluate studies for their validity. You build arguments. You build a case in a paper to argue for the study's internal validity. You can't really quantify it. You have to build a set of propositions supported by your study design and the methods that you use to mitigate the threats to internal validity. External validity, on the other hand, addresses whether the inferences that you are drawing about the intervention, and let's just assume that they are correct and credible. The next question is, can they be generalized to other patient populations and to other settings? In the learning health system science context, we're asking how generalizable are the results to the real world? Real world patients, real world clinicians, real world settings. We're trying to figure out whether the intervention has a beneficial effect on participants outside of research settings. So we're going to now walk through 8 internal threats to study validity and 3 external threats to study validity. And again, this is material that I really absorbed when I was a doctoral student at Johns Hopkins and learned this in my health services research classes. It was on my comprehensive exams when I was moving through the PhD process. And I come back to it over and over again in order to strengthen study designs that I've put together over the years and try to mitigate the potential threats to study validity. It's a very useful framework. Again, I think this applies both to experimental interventions as well as quasi-experimental interventions. Excuse me one sec. Fighting off the cold, I was going to take a quick drink of water. All right, the first one is historical effects. Now, these are, as economists say, externalities that can alter the intervention effects. These externalities need to occur before your baseline assessment and the post-test or the follow-up assessment. Let me give you an example. Let's pretend for a minute you're assessing an intervention that's intended to reduce levels of anxiety. You do your baseline assessment, you deliver your intervention. And then a recession hits. And recessions have profound impacts on families, on parenting, and on children's anxiety. So you may falsely conclude that the intervention had no effect because there was a historical effect that actually led to levels of anxiety to go up. Let me give you another example. Let's pretend for a moment that you are involved in an evaluation of a quality improvement program. That program is designed to lead to more judicious use of PCR testing for COVID. So you do your baseline assessment in the clinics, you deliver your intervention, your QI intervention, and then boom, before it's over, there's a new guideline that's issued by the CDC on who should get PCR testing, who shouldn't get PCR testing, and it's adopted by a bunch of professional societies. So now it looks like your intervention had a great effect, but in fact, it was due to the new guideline. So the solution to historical effect is somewhat obvious. It's get yourself a comparison group, because historical effects, if the comparison group is relatively similar to the intervention group, ought to be similar, right? The historical effects ought to have the same effect on both the intervention and the comparison group. But another approach is to not just do a single pre-post assessment, but actually have multiple assessments before the intervention starts and multiple assessments afterwards, so-called interrupted time series. I'm going to show you an example of that in a sec. Sort of a brother or sister to historical effects is maturation effects. These are within person changes that can alter intervention effects. So individual growth, people learn, there's some kids' developmental change, people in a particular study may experience fatigue. These are all things that happen internally that have similar kinds of potential effects as historical effects. And again, you can mitigate it by having a comparison group well chosen. However, if there are important differences between the comparison group and the intervention group, you may have what's called a selection history or a selection maturation interaction. In other words, it's possible that the historical effect or the maturation effect has differential impacts on the two groups. And so you need to weigh whether or not that's possible or whether it's likely to be going on. Another approach is to mitigate this is to do repeated measures. So here's an example of an interrupted time series. So let's just talk about intervention A as being the red line. And if you just did a pre-post, that would be the red dots. And so let's pretend that for a minute we're measuring anxiety on the PROMIS T scale, where 50 is sort of average. And we see that anxiety goes down. If you only did pre-post, you could have historical or a maturation effect explaining that change. But if you have multiple assessments beforehand, such as shown on this chart with all those purple dots, you have a slope that you would predict to be going up afterwards. But in fact, what you see is not only a change in the intercept, but you see a change in slope afterwards. So you can mitigate against the historical or maturation effects to some degree by having the repeated assessments. Now, if the intervention and the historical or maturation effect all occur at the same time, then you're toast. But this is one design, time series, interrupted time series, that does help address, when you only can do your assessment in one group, does help mitigate some of those externalities and internalities that we call historical and maturation effects. Third, threat to validity, testing effects. This is when the pre-intervention assessment affects the post-intervention assessment. So the most common example here is that if you are conducting an intervention designed to improve physical functioning, and you use the same questionnaire, exactly the same questions before and after, people may learn how to answer those questions. They may change their responses after the fact because they recall what they said on the first go round. So you can address testing effects, again, through a comparison group, but a really kind of innovative approach for addressing testing effects, even in randomized controlled trials, is computerized adaptive testing. Let me explain this in the next couple of slides. So if you were just interested in physical functioning and you gave this questionnaire, people may look like they're getting better because they may simply change their responses because they've now been conditioned to the scale. Same questions, same response options given before and after. But what if we used a different approach? What if we didn't give the same items to the same person each time they were assessed? Well, that's called computerized adaptive testing. How does that work? It has a really cool property of arraying a bank of items, a set of items on the same scale in which the population distribution of the latent variable, in this case, it's physical functioning or mobility, is arrayed. So let's start with the population. You've got kids who are bedridden who would score very low, so kids who are typical, and then kids who are very active who would score up high. And you could think about that as a bell curve, right? So there aren't that many kids who are bedridden, there aren't that many kids who are on like the extreme, nearly, iron kid level. So the people here are moving into the scale, and so each person can be assigned to a score somewhere on that bell distribution. And then what you do is you create a whole set of items that assess physical functioning. Some of these items are going to be useful for assessing people at the low end. So if I'm an iron kid, a kid who does triathlons, and I'm asked, can you get out of bed by yourself as the bottom item? That's got no relevance to my life. I want to be able to answer, I can run a mile. In other words, the information you get from the low item is almost zero compared with the information that you get at the top end when you're asking about somebody who's at the high end, and then vice versa. All right. So the trick with computerized adaptive testing is that it arrays the items along the scale where they work best. And this is called item calibration. And items are calibrated using fancy statistical models called item response theory. But the key point here is that if you look at that, I could get out of bed by myself, that would be item 1, and I could run a mile would probably be item 9. So now you have the ability to match items according to individuals' pattern of responses. Because if you gave everybody in a population item 5, the bedridden person would score low, and then you might give them item 2, and you might give them item 1. Each time increasing your information about that person's level. But on the flip side, you could imagine that the iron kid, the kid who does triathlons, would endorse item 5 positively, then you might give item 8, and you might give item 9, zeroing in on their level of physical functioning. So computerized adaptive testing starts with presenting an item that works well for about half the population. Here at physical functioning on the left-hand side, here's a ruler. You zero in on a score that's about, these are in standard deviation units, so about 1 above the average, 1 standard deviation above the average. And now you give another item that works well in that around there, and now you can zero in on with more precision to a somewhere between 1 to 2, and now you give a third item that works well there, and you can actually add precision. So with anywhere between 3 to 8 items, computerized adaptive testing for health scales can provide estimates of an individual's level of that latent variable with reliability of 0.9 or higher, highly precise level of precision that you need for individual level decision-making in clinical care. And importantly, whether I take items 1, 3, and 7, you take items 2, 8, and 9, our responses are all scaled on this same scale. So our scores are comparable, right? That's a really important property. And so even as an individual, if my level of physical functioning has changed, I'll receive a different set of items in the follow-up than I did at baseline. And this is the way computerized adaptive testing mitigates the threat to study and validity of the testing effect. The next threat to validity is instrumentation effects. And this is maybe the simplest one to see and the simplest one to address, because it results from different measures being used before or after a change in internal scales. So let's talk a bit about the first part, using different measures rather than a change in internal scales. So an example of that is the longitudinal study. Let's say you've been giving life satisfaction measures for years, and you've been using the Cantrell ladder, which is a single item displayed on a ladder. And then that item worked well for kids, but then now they're moving into adulthood, and you now say, well, I want to give the promised life satisfaction scale. Well, those are different measures, and you might see a change simply by virtue of changing that measure. So obviously you can use the same measure to mitigate that, but you can also do what's called statistical equating. I'll get to that in a sec. But importantly, instrumentation effects also refer to changes in a participant's internal scales. So as people get sicker, think about fatigue for a minute. Let's say you have no illness, no fatigue. You don't experience fatigue at all. So the breadth with which you experience fatigue is somewhat narrow. But if you have a disease where, like say Crohn's disease, where you can feel extremely fatigued, or well, your scale is bigger. So in the same person, the scale, your internal scale that we're trying to map our responses to can vary. That's called response shift. And it's really hard to find. It's just important to be aware of. In other words, it's hard to find empirically. There aren't good methods for identifying response shift, but we know it occurs through qualitative methods. There are studies that have linked different measures. So here's a paper by Bryce Reed that shows that the PROMIS pediatric and adult emotional distress measures, depression, anxiety, and anger, have been statistically equated. And so through what are called equating methods, the investigators, and also most of these people are friends of mine, have been able to calibrate the pediatric version and the adult version of the same concepts onto the same scale. And that gets over and gets past and addresses instrumentation effects of using the promised pediatric version versus the promised adult version. With Dave Sellow's leadership at Northwestern now, a number of measures have been equated that assess the same concept. So a number of depression measures now have been equated, such as the PHQ-9 and PROMIS. So if you were to change from the PHQ-9 to the PROMIS measure, if you didn't make any change in the scale, you'd have an instrumentation effect. But if you use the equating equations, you can rescale both and put them on the same scale and mitigate the possibility of instrumentation effect. We've all heard about selection effects. This is allocation to intervention versus comparison or control groups that occurs in a non-random way, potentially creating systematic bias, unequal groups. You know, an example here is that a clinician chooses which medication to use in a study that contrasts ACE inhibitors in patients with hypertension. So we are now left to compare, say, Ramapil with enalapril, and we haven't randomized patients to the two groups, and we have patients assigned to one medication versus the other based on what clinicians decided. And of course, you know, they may have a bias that enalapril is more effective, and they may allocate enalapril to patients who have more difficult to control hypertension, so-called confounding by indication. So selection effects is thorny. They're present in all non-randomized studies. Even with the best causal inference methods, they're still potentially present. And you know, the best solution is to randomize. When you can't randomize, you can use a variety of statistical methods to try to equate the groups. The problem is you can only hold constant what you observe, what you have information on. The unobservables are the thorny little things that annoy us and actually are major threats to study validity. And so you have to try to create in your reports and your papers an argument that you've addressed all of the important factors that may influence the outcome. And that's a big challenge. Multivariable matching is now increasingly used in big data initiatives. Literally hundreds and hundreds of variables are used to do multivariable matching. You could actually match one individual patient to literally hundreds of other patients on hundreds of variables in a big data set like PEDSnet. Regression effects, actually, I don't think are thought of enough. This is when a group is identified by high or low scores. And just over time, those groups regress to the mean. And this was a real thing that actually led to some companies going out of business. I got involved when I was at Hopkins in evaluating a number of disease management programs. These are programs that would identify patients with like diabetes who were costly in 1 year. They put them into a care management program, and then they showed in the subsequent year that the costs had come down. Well, when you looked at a comparison group that was similar and didn't get the care management program, you saw that there was regression to the mean. And these disease management programs were making all kinds of claims to employers that they were saving them money, but in point of fact, there was only regression to the mean, and the disease management programs actually had very little to no effect. The other threat to study validity that I like to think about whenever I do particularly complex interventions are sometimes called diffusion or social interaction effects. This is where participants are not masked to the intervention, and they figure out that other participants are getting something that they're not. So an example would be you're running a study in primary care practices, and you've randomized clinicians in primary care practices to some work with an improvement coordinator, but others get usual care, right? So within the same practice, you've done your randomization, so you've done a good job trying to hold the clinicians constant. But then they start comparing notes. And the ones who didn't get the coordinator get a bit resentful. And that's going to affect your study results. Or maybe they start sharing the coordinator and there's diffusion. So one way to address this is when you're interested in clinical practice is to use cluster randomized trials rather than randomizing individual clinicians, randomizing practices. Another approach is to use what's called waitlist randomization, also the step wedge design. This is where everybody gets the intervention. They just get it at different times. So you roll it out over time so that some people who are going to get it serve as controls, while others are in the intervention group. And then you mask whenever possible. And then finally, attrition effects. This is when participants drop out or they're lost to follow-up or they die. And the attrition effects can occur differentially, even in a randomized controlled trial between intervention group and control group. So for example, individuals who are randomized to tight blood pressure control may drop out of the study more frequently than those in a comparison group because of the adverse effects of the tight blood pressure control. So you want to pay close attention to retention. You might use an adaptive trial design to address this so that if people start experiencing adverse effects, you build into your protocol specific changes that you would make, and then you evaluate these different treatment strategies. And then conventionally in a clinical trial, you use intention to treat analysis to estimate treatment effects. Now, 3 basic types of external validity. There are many actually, but I like to boil it down to 3. The first is, can the results from the study be generalized to a different group of people? And this is a huge thing in pediatrics, right? There are 50% of drugs that we use in pediatrics are used off-label. They have evidence in adults, but no evidence in kids. So we use this hand-me-down evidence from adults. We're always asking the question, can we adopt the evidence for adults and apply it to kids? And there's not really a good solution to this. One approach that we've been thinking about taking and have been exploring is to essentially use observational methods in pediatrics to replicate clinical trials that were done in adults and then compare the treatment effects that we get in pediatrics with those that we got with adults. And so far, we've done that a few times. We've seen, comparable results. But of course, the best approach here is to use probability sampling to ensure diverse populations. Ecological validity isn't thought about enough. The question always is, did the effects of the study depend on time of day, location? Are they dependent on like a really charismatic research team? Could historical effects have been responsible for that? Do participants have knowledge of the research study, so-called Hawthorne effect? An example of ecological validity might be a cognitive behavioral therapy trial shows reduction in anxiety symptoms measure over 8 weeks, where the intervention is delivered in clinics and the anxiety is assessed in clinic settings. If you then want to know whether the same treatment is effective in the real world, and you assess anxiety at home, can you now conclude what you learned from the first setting is going to be in the clinic setting is going to be applicable in the home setting? And the answer is probably yes, but not always, particularly something like anxiety. You might see kids in particular reporting much more anxiety in clinical settings than they would in home settings. So the intervention may look less effective in the real world, have less ecological validity when you move the assessments to the home. The way to address ecological validity is replication, replication, replication. So replicate the intervention in a variety of different times of day, locations, different research teams, et cetera. Then finally, complex interventions are those which have multiple parts, in some cases too numerous to count, such as some complex surgeries. And it's not clear what part of the complex intervention may be responsible for the effect. So you could do a randomized trial and show, hey, yeah, this complex surgery is effective versus an alternative surgery, but are you actually going to be able to replicate that complex surgery because there's so many different moving parts? Or an intervention that includes a health coach, a phone app, text messaging, and a clinic visit, perhaps all that together improves nutritional intake. But with all those parts, are you able to replicate that same intervention elsewhere? So the way to address this is to write out detailed protocols, publish your protocols, and then as you implement the intervention, do a process evaluation to look at its fidelity and to truly understand the intervention as much as possible. So that's it. You've got some different ways of thinking about intervention studies. You've got, in particularly pragmatic clinical trials, you've got a framework for thinking about study internal validity and 3 ways of thinking about study external validity. And all intervention studies, even those with randomization, have several threats to their validity that you need to address in your study design, as well as in the conduct of the study, and then when you report it, how you develop claims to build an argument that, in fact, the inferences are credible and they can be generalized to A, B, and C population and X, Y, and Z setting. Always think about these threats to validity when you are conducting any kind of intervention work. And please be prepared when we meet to discuss these threats to validity, because we're going to go over a number of experimental and quasi-experimental study designs and really drill this home. Thanks very much for your attention, and I look forward to our session together.